Okay, we have 2 minutes. Good morning, buenos días para todos. En 2 minutos comenzamos. Vamos a esperar cumplir el tiempo necesario para poder comenzar esta charla, excelente charla. How is Barbara, Anthony?
Very good, thanks.
Please say hello to her.
I sure will. I sure will. What's Nicole up to? Where is she now?
It's in Navarra. Too far from here.
Yeah.
Yes. Navarra, Pamplona. I told her, don't run ahead the bulls, please. Do you know the Fiesta de San Fermín? It's in Pamplona, where bulls run and the people is running close to them. Yes. My first recommendation was don't do that. Okay, I will pass to you, Anthony, the command of the talk. Okay. Okay, you can put your screen, please. Okay.
See it okay?
Excellent.
Okay.
Okay, so we are on time. Let me do some introduction, please. Buenos días a todos. Muchas gracias por su presencia. Respetando el tiempo de cada uno, vamos a comenzar puntualmente. Me voy a referir en inglés en respeto a nuestros invitados. Good morning, everybody. Thank you very much for your presence here. And let me tell you that this is the fifth year that we are online with our visiting professor online by Zoom. So today we have Dr. Anthony Caldamone and Dr. Si Yang Wu, who are so gentle to be with us and to talk about this amazing presentation, The Art of Scientific Communication, Writing, and Presenting. Tony, please.
Hey, good morning. Good morning, everyone. It's a pleasure to be with you this morning. And thank you again for the invitation for both Yang and I to participate in your lecture series, which has been so well organized and so complete. Today, we're going to be talking about something a little bit different off the clinical path, and that is scientific communication. And we'll do it in 2 parts. I will start off by talking about manuscript writing, and then Yang will talk about presentation and covering the spectrum of what we think scientific communication should be. First of all, greetings from Providence, Rhode Island, and from our parent university, which is Brown University. It's a beautiful time of year here in Rhode Island because it's autumn and the leaves are changing colors, as you can see. So a wonderful time of year. Now, neither of us have any industry affiliations, but we both serve on the editorial board of the Journal of Pediatric Urology, so you may see some bias in our presentations in terms of what we refer to as far as journals are concerned. So I will start off by giving you an overview of what I think the editors are looking for when you submit a manuscript to a journal. But before I do that, I will give you my major disclosure. My major disclosure is that I have wonderful memories of times that I have spent in Santa Cruz. And I want to say hello, especially to all my friends there, and thank them again for all the hospitality that I've had on my visits there. They will never be forgotten. Thank you. Okay, why am I qualified to give this talk? The reason I'm qualified to give this talk is because I have had so many abstracts rejected and so many manuscripts rejected that hopefully I've learned something from this. And if I've learned from all of these mistakes, that would qualify me to speak to you on this topic today. And my objective is to go over a manuscript preparation and talk about each of the areas and sections of a formatted scientific research paper and discuss what I think are the major mistakes that are made in each of these sections. Now, we'll start off with something very, very simple and maybe very, very obvious, and that is make sure that your submission goes to the right journal. About 6 to 10 times a year at the Journal of Pediatric Urology, we receive a manuscript that just is not good for our readership. So whatever your message is, whatever your content area is, choose the journal that has the readership that would benefit from this. And then once you've chosen that journal, go right to the guide for authors, because that has to be followed exactly, including the type of article and content, which may be specific for that specific journal. It will save lots of revisions. It's the most common reason for an outright rejection, that is, a paper that does not go through scientific peer review, which happens up to 30 to 40% of articles submitted, believe it or not. And finally, another general point is make the first submission a good one. Because as I always like to say, you only get one chance to make a first impression. So try and make that impression a very, very good one. Now, let's talk about the title. Juliet in Shakespeare's Romeo and Juliet argued that a rose by any other name would smell as sweet. Well, I don't agree with Juliet on this, I must say, because the title and the name of your paper makes a big difference. And the reason is that the name will convey expectations to the reviewers and expectations to the readers. And if the title is not exact, they may be looking for something different and not seeing what they're expecting in your paper. Let me give you a good example of this, a personal example of this. Dacia Dorenzo from Pescara, Italy, wrote a very, very nice paper on the long-term follow-up of primary non-refluxing megaurethra. Now, let me give you the history of this. This took over 2.5 years in the submission process, in the peer review process, with 3 new submissions, 10 revisions, and 3 title changes. They didn't like follow-up of primary megaurethers. They didn't like follow-up of primary obstructive megaurethers. And we finally all agreed on primary non-refluxing megaurethers. So the title will make a difference and make sure that it conveys and leads the readers and the reviewers to the message that you're trying to get across. The introduction. Keep it very short. 1 or 2 sentences, all you need on the historical perspective. And then why does this matter? What's the clinical implication of this? And how will it make a difference in your practice? Finally, state hypothesis. This is something that is oftentimes overlooked. It is not sufficient to say, for instance, that this is a review of our last 100 laparoscopic nephrectomies. What you should say is, we reviewed our last 100 laparoscopic nephrectomies to determine if something. So what is your question that you're trying to answer by reviewing those laparoscopic nephrectomies? State the rationale for the hypothesis. Maybe because other authors have determined something differently than you're expecting. It's important to have a hypothesis for your paper, not just a review. In the materials and methods, think about writing a recipe for a cookbook, insofar as someone would need to either recreate the study, the protocol, or the procedure based on what you put in the material and methods. And for instance, if you're reporting on hypospadias, if each of these variables contributes to your outcome measure, they all need to be included. If you're looking at a primary outcome of fistula from a hypospadias repair, all of these factors play a difference. On the other hand, if you're looking at Cordia recurrence, maybe you don't need all of these variables in there. So insofar as the details may affect the outcomes, include all of the details. Tell us what the study design is. Prospective studies are always better than retrospective studies, because retrospective studies, you're doing a chart review, and there's oftentimes data that's missing that you cannot go back and recapture. It's impossible to do that. Prospective studies, you've started with a database, and that's very, very helpful and move forward. It eliminates a lot of bias, of course, in the process. And I usually say that if you're going to put together a database on your patient population, pose your questions first. What question are you going to try and answer, or questions you're trying to answer with that database? Then set up the variables so you're not going to be as likely to have to go back and look at it all over again. Finally, what is the denominator? It's critical to define what the inclusion and exclusion criteria are. If you're looking and reporting on a novel robotic intravesical reimplantation technique, what are the anatomical factors that predict the success? Which patient should you use this technique on? And most importantly, who should you not use it on, and why? Define the follow-up and the outcome parameters. Make sure that it's a reasonable follow-up for the outcome parameters that you're trying to measure. If, for instance, you're looking at hypospadias fistula rate, to get back to that topic again, evaluating this prior to toilet training is probably not sufficient, because you're going to miss a lot of fistulas that will not present, and the parents will not notice them, and you will not notice them until after the child is toilet trained. Similarly, an earlier follow-up on incisional hernia recurrence, not reasonable for a short follow-up in that cases. And as regarding subjective outcome measures such as cosmetics or satisfaction, it's important to indicate who was the observer. Was the observer independent, or was it biased because it was a surgeon, or was it a patient observer? Remember that subjectivity in this regard of outcome measures that are subjective is very, very variable. Define the statistical analysis, and I'll get back to that in just a second, and indicate that you've had ethics committee or IRB approval for your study is essential. The results should mirror the materials and methods. The common mistakes in the results are that it's disorganized in a confusing sequence. Again, follow what you've put down in the materials and methods, or it's incomplete. There's data that you acquired in the material methods, but you don't report them in the results. Or there's inappropriate data that's presented that you didn't measure, that you didn't mention in how you obtain that in the materials and methods section. And don't try and interpret the results in the results section. I'll get back to that in just a second. Make sure that your numbers add up, particularly if you have a large patient population. Account for all the dropouts and all the exclusions, and setting up a flow chart in this regard, I think, helps the readers and helps the reviewers tremendously. Again, no editorialization or opinions in the results section. Present your data without interpretation. Make sure that the numbers, total numbers and percentages, are both reported. And do not be repetitive of the text when you put together your tables and your graphs. You don't want redundancy. The tables and the graphs should be supplemental and not redundant to the text. And again, I'll get back to making sure you use an appropriate statistical evaluation. There are so many different methodologies for statistical evaluation that if you try a number of them, you'll probably end up one that shows you a statistical significance. However, it's important to remember that statistical significance is not equivalent to clinical significance. And let me give you an example of that. If you have a study design that's looking at a cohort study comparing two different orchidopexy techniques, where reascent rate after the orchidopexy is your primary outcome, and it's a highly powered study with a lot of patients, 3,200 patients. Technique 1 results in a 10% reascent rate, whereas Technique 2 results in a 15% reascent rate. And if you look at that statistically, depending on what you use, maybe just a standard paired t-test, it comes out as statistically significant. The conclusion from the authors would be that Technique 1 has a significantly lower reassent rate, and that's true. However, it's probably not clinically significant, a difference of 5% in the reassess rate, unless, of course, the outcome is much, much higher. But in this case, it would not be. So statistical significance is not always equivalent to clinical significance. Remember that. Finally, we get to the discussion. Don't write a textbook chapter. Don't be encyclopedic. I use this quote over and over and over again by Pascal, a French mathematician, who said, if I had more time, I would have written a shorter letter, right? It takes a lot more time to condense a discussion down to the pertinent points, does it not? First of all, summarize the data in the first paragraph. What is your take-home message? Right in the first paragraph. Then choose 2 or 3 of your outcomes to focus on. And in choosing those, compare those to the literature, the pertinent literature. You're not going to be able to do all the literature, and you'll likely miss something. But hopefully it won't be an article that was written by one of your reviewers, right? That would be pretty bad luck. State why the results are important. Are they generalizable? Are they applicable across other study populations? That's important to say. Avoid speculation. If the exact significance is not perfectly clear, state so. It's okay to use like probably or is likely, because appropriate caution in the interpretation of your results is important. And finally, discuss alternative interpretation of your results and why these other interpretations are not as likely as the interpretation that you're focusing on and the message that you'd like to get to your readers. It's imperative to state the limitations of your study. This is not a sign of weakness, because what it does, it tells the reviewer that you've reflected on the results, you've put them into a larger context, and you've done self-evaluation of your study design. Very, very important. Finally, the conclusion. The biggest mistake that everyone makes is that they extrapolate or they overstate the conclusions. Be certain that the conclusions are well supported by your data. Be honest and be humble in your conclusions. Do not extrapolate. I'll give you a prime example. This is a very often cited article that was published in about 2005, 2006, at the height of the arguments as whether we should be doing VCUGs on patients, whether we should be discovering reflux, whether we should be using antibiotic prophylaxis. The author's conclusions from this study was that antibiotics were not necessary in children with reflux. Think about that. But if you read the article closely, their exclusion criteria were that they excluded patients with grade 4 or 5 reflux. Their exit criteria, patients who were dropped from the study, were patients who had 2 episodes of pyelonephritis and whose parents failed to give them the antibiotic prophylaxis. So I think that's an inappropriate conclusion. The appropriate conclusion for this study is that antibiotics are not necessary in children with low to moderate grades of reflux, without breakthrough urinary tract infections, and have a compliant family. That's the appropriate conclusion. Make sure your conclusions are supported by your data. How do we deal with revisions and how do we deal with rejection? Well, there are basically 2 responses. Excuse me. There are basically 2 responses. You can roll over and play dead. You can say, I'm not going to go through this ever again. I failed. This was a miserable experience, and this has ruined my academic career. Or you can say, did they really read my paper? I can't believe that this was rejected. There's no way that they're competent reviewers. Those are your 2 responses, right? Well, in handling revisions, it's important to address each and every comment. You don't have to agree with the reviewers. It's okay to challenge their critiques and to challenge their concerns, but you have to give an appropriate explanation for why you're challenging their critiques. And you can disagree, but do it respectively and with no emotions, please. Because attitude is everything in the response to a revision. Most journals will have a specific type of format that they like you to use in answering the revisions, in your rebuttals to the reviewers, and track these changes on your revised manuscript as well. This will do a tremendous service and get the editors on your side, believe me. And what about rejection? What about a rejected paper that you think clearly the reviewers missed the point on this? It's perfectly fine to present your arguments to the editor. Send them an email. Tell them that we are quite certain that the reviewers might have missed the point, might have missed the message of this and went off on a different tangent. What happens, for instance, in the Journal of Pediatric Urology when this occurs, and we get this type of letter, is we send the letter with the cogent points from the authors, the article, the original submission, and the reviews to each of our 6 senior editors, if you will, and we get a consensus. If the consensus is, well, the authors are right, reviewers might have missed something, then we assign a new managing editor and we invite new reviewers for a whole new peer review process. I think it's a fair and it's a transparent way to deal with this problem. And I'll tell you, in the last 2 weeks, we've had 2 of these situations. It happens pretty often. I want to finally say a word about the difficulties that non-native English-speaking researchers and authors have. It's important, of course, that we have a single universal scientific language, and there are obvious advantages to that. But what's sometimes ignored are the barriers and disadvantages to that. The barriers that it presents to publication and writing, and the increased time and effort it takes. Because there clearly has been demonstrated in the literature some bias in this regard. Because authorship from non-native English-speaking authors has a much higher manuscript rejection rate and a much higher requirement for revisions for language and grammar related issues. No question about it. And that's costly. That costs the authors a lot of money. No question about that. And it's clearly been shown that artificial intelligence may be able to help us in this regard because it has the ability to potentially level the playing field, does it not, as these articles have shown. However, journals need to figure out how to set the appropriate guidelines and make sure that it's transparent for the utilization of artificial intelligence. At the Journal of Pediatric Urology, we are currently working on this. In fact, we've had discussions about it just this week in order to set the guidelines that we can have our authors use in order to identify that they've used AI in their manuscript preparation. This is a nice article that reviews that from the Toronto group that they published recently. I'll also let you know a heads up about a pilot project that the JPU is working on, and that's the narrated PowerPoint. And this is a format that's different than the scientific formatted publication of introduction, materials and methods, etc. This you would present to the journal a PowerPoint that you narrate, a short text to summarize, formatted slides that are narrated, and we'll go through a peer review process as well. This is the first year we're piloting this for specifically invited papers to see how this goes. And over the next 6 months, you'll see several of these in our journal issues, and we would appreciate any feedback on this. Why did we go this route? Because we recognize the difficulties in writing and submitting for certain authors and certain presenters from our meetings. And also this would help readers with their difficulty in trying to keep pace with all of the escalating information and all of the ballooning articles that appear in our scientific literature. So here are my take-home messages. Choose the journal that's the right fit. Follow the guidelines for authors to the letter. Follow it specifically. Prepare a good first manuscript. Have your study design reviewed before the starting point if possible. State the hypothesis. Explain the clinical significance of your study. Try not to take the reviewer's and editorial decision personally. Stay unemotional in it. Respond to the critiques completely and unemotionally. But you know, even sometimes when you have your paper accepted, you've been through such a battle in the process of getting to that point, you look back and say, was that really worth it? I mean, is anyone going to read this anyway? Well, I'd have to leave that up to you to decide, but that's what the peer review process is all about. And that's our hope, that we can improve scientific communication through the peer review process. So once again, I want to thank all of my friends and say hello to all of my friends in Santa Cruz, and hope that I'll have an opportunity to see all of you again at meetings at Santa Cruz or back in Providence, Rhode Island. You are all invited. Muchas gracias. With that, maybe rather than entertain questions right now, German, why don't we go to Young's talk, and then we can deal with some questions at the end, if that's okay with you.
Perfect. I agree totally. I will
Okay.
pass to Xiang, the
Okay, I'll
presentation.
stop the share here, and now it's all in your court, Yang.
Okay, I will take it off. And where is Xiang? Xiang is here. Okay. Xiang, please give me 10 seconds before presentation. You are on command right now. You can put your presentation. I want to thank you, Dr. Xiang Wu, from Rhode Island. He's a professor of surgery and pediatrics at the Warren Alper School of Medicine at Brown University, chief of pediatric virology at Hashborough Children's Hospital. Xiang is our friend from some years ago. He did a nice presentation in 2020. Xiang, thank you very much for being with us again.
Thank you. Great to speak to you again. And following up on what Dr. Caldamone has presented, I'll be talking about the presentations that we commonly give at meetings, whether they be at within our own department, at national meetings or international meetings. So this talk is based on sort of personal experience and advice that has been given to me over many years by my mentors, and also this book, Michael Alley, The Craft of Scientific Presentations. If you can get a copy of this, a lot of the illustrations that I'm going to use today come from this book. And it's a very, it's a short book, but it's really helpful in helping us design good presentations that clearly convey what we want to give and the information we want to give. So if, say you're invited to give a talk, or you've had an abstract accepted at a meeting, before you even start thinking about how to do the presentation, you should think, who is the audience here? Am I speaking to medical students? Am I speaking to residents, general urologists, or am I speaking to my peers, a group of experienced pediatric urologists? Because that will alter the depth and the detail and what you're going to emphasize to your audience. Second question you should ask is, well, why is my talk important to them? What are they hoping to learn from this? Hopefully it won't be something that they've heard 100 times, but it will be something that will challenge them or make them think about how they do surgery or how they approach a patient. But, the problem is we go to so many talks, not all of them are memorable, and sometimes half an hour later, you don't remember what the point of it is. You have to go back to the abstract book and see what happened there. So my preparation for giving a talk is, first, I want to come up with a good story, because that's what people will remember from your talk. They might remember a few of the illustrations, but basically they remember the story that you presented them about this physiology, about the surgery, about your approach. Second thing you need to do is to design your slides so that they are not in competition with what you're saying, and that they're illustrative, but you're also not making the audience read too much. And I'll talk a little bit about some of the little drawbacks and problems with PowerPoint and how you can try to overcome them later on. And finally, you need to practice your talk several times. So it's obvious that you thought about the talk and you're not just reading your slides to people. So when you think about the audience, you have to think, what do they want? And these are sort of my own personal things that I'm always looking for within a talk. Give me a story. Give me a way to understand this very confusing topic. And so you might say, well, I need to understand hypercalciuria. How do I remember absorptive, non-absorptive, renal leak, and stuff like that? I heard Charlie Pack give a great talk once. I remembered what it was for about 30 seconds, and then the next day I could not remember exactly what he said, but it was very good. If I had written it down, it would have been better. I would have probably understand hypercalciuria better. Or maybe you are presenting something new you've discovered in the lab. Maybe there's some new physiology or anatomy that you've discovered that affects how we treat patients, how we do the surgery. If you're working on animals, a lot of times you're developing a new drug. And so you want to explain, what does this drug do? How does this help the kidney drain? How does this help the bladder contract? How does this help the urethral sphincter relax when I'm trying to void? And as surgeons, obviously, we always want to learn, how do I do this surgery that you are showing great results from? How did you do this? What's the difference between what I'm currently doing? And how did you come up with that idea? Is this something I can do, for my patients? So what we'll cover in this talk is how to structure your talk, how deep to go into the topic, and some presentation tips on how to come up with your slides. So when you're giving a talk, you should think of it almost like you are delivering a play. Okay, and a play has 5 acts. You have the beginning, you have the 3 acts in the middle where the conflicts gets resolved in act number 3, and then you have the results of that and the conclusion in acts 4 and 5. So when you think of how you're going to structure your talk, give the audience a beginning and give them an outline. So, we've told you we're going to do the structure, the depth, and the presentations. And then, so you're going to talk about this in the middle, and then you're going to come down to your ending. Okay? Now, what's helpful is that as you're going through these topics, it's sometimes good to have a slide that transitions between one topic to the other. So here's an example. Okay, in this talk, and this is a talk about mercury and their hypothesis about how they see the cycle of mercury within the environment. And they're going to talk about their theory, how they did the measurements, and what this actually means. So what the presenter here has done is every time they jump from this 1 to 2 to 3, they put the slide up just so that the audience knows where they are within the talk. And then finally, it's always great to have a good concluding slide to summarize what you've said, and if it's a diagram, even better. The reason a good concluding slide is very important is a lot of times if you're having the discussion of your talk right afterwards, this is the slide that stays up for about 10 minutes. And people can look at this, they can think about it, and they can pose questions. So that's how we can structure the talk. But then you have to think about the middle of the talk, the parts 2, 3, and 4, and how to structure that correctly so that you can actually hit all parts of your audience. Now, within your audience, you may have medical students who are just learning. You could have a writer from a journal or that's there. So these may be sort of non-technical people, or just people who are just beginning to get into the topic, and they will understand probably your introduction. And then when you go into the middle, the meat of your talk, you're going to have people, say a general urologist who does this and is sitting in because they're so much interested. And then you're going to have people like pediatric urologists who know the topic very, very well, and they will want all the nitty-gritty here. So the reason for always coming back to the general audience is that you will lose a good deal of people by the time you get down here. People are going to fall asleep if they don't understand what you're going. So if you keep going deeper and deeper and deeper, you're going to put more and more of the audience to sleep. And then you better come back up so that the rest of the audience can understand what the point of your talk was. So let me give you an example, okay, and these are based on some talks I've given to the ICCS, International Children's Continence Society, about neural stimulation of the bladder. Now, I know not everybody is super interested in this topic, but I want to show you a good way to do it and a not so good way to do this, okay? So here's the introduction part, okay? So this talk is about efforts to stimulate the bladder when it doesn't contract properly. Now, historically, the first bladder stimulators were designed by Giles Brindley in 1977, who came up with the Brindley FineTech stimulator, as well as Emil Tanago and Rick Schmidt in 1982. Dr. Tanago was my mentor during residency in San Francisco. And this was really groundbreaking at the time, because what he thought was, if I can take out the dorsal roots, which prevents the afferent nerves from bringing information back to the bladder, and I remove the connection to the pudendal nerve, then I can try to take out the external sphincter, which is the problem when you have a neurogenic bladder, because the bladder is trying to contract against a sphincter, which actually contracts at the same time. And so what he did was to cut this and to cut this, and then put a stimulator here. And the idea was to just stimulate the bladder to contract while taking out the sphincter, which was fighting against it. So this has been here and in practice for many years. You probably don't see a lot of them, because over time there are a lot of problems with it. So more recently, people have noticed that you could do something similar without going as far as removing the dorsal roots and cutting the pudendal nerve. Obviously, if you cut the pudendal nerve, then you have some side effects from a sexual standpoint in terms of erections. Okay, so this is an experimental setup where we've taken some cats, and what they're doing here, which is a little different, is that they're using both the left and the right pudendal nerve, and they are using stimulation both to inhibit the bladder when you want storage, and then you are actually blocking the external urethral sphincter when you're voiding, and then switching on the same electrode that was inhibiting the bladder to cause the bladder to contract. So with electrode 1 here on the left side of the pudendal nerve, you have a 5 Hertz inhibition of the bladder when you're trying to store. Electrodes 2 and 3, which are both on the pudendal nerve on each side, are set at 10 kilohertz, and this is to block the afferent activity to the sphincter. And once you block it, then you switch electrode 1 to 20 to 30 hertz to stimulate the bladder after you've done the block. Now, this is done in a cat with the T9 to T10 transection of the spinal cord, and these are planted lateral to the tail. The stimulator is not that large. You can see here's a quarter from the United States currency, and the 3 electrodes are there. The cats had weekly cystometrograms. There's only 4 of them. Cats are hard to manage, and you have to squeeze their bladder several times a day, like doing CIC on them, in order to empty the bladder while they're recovering. 1 cat was able to empty 80%, 3 cats were able to empty 100%, and they were able to suppress the overactive bladder that was seen, and they finally did an anesthetized study. Okay, so what I've just done there is taken the audience into a very, very deep dive into this topic, which has probably lost a great deal of people. Okay, so here's another way to do it. So you can see it's the same picture, but I don't go into the same detail here. Okay, so I'm going to say is the idea here is we're going to use the pudendal nerve to stimulate both the bladder to contract, and we're also to get the external urethral sphincter to relax. We have 1 electrode here, which is set up to inhibit the bladder during storage, and we have electrodes 2 and 3 here on the left and right pudendal nerve, which are meant to block the external urethral sphincter. If you look at the diagram here, during storage, electrode 1 is inhibiting contractions, and then when we want the cat to void, we turn on electrodes 2 and 3 at different frequency, which then relaxes the sphincter, and electrode 1 gets switched to yet another frequency, which then causes the bladder to contract. And here's the final results. If you don't turn on the stimulator, there's very little voiding. There's a high post-void residual, and the amount of urine that comes out is very low. If you just stimulate the bladder to contract, you get some contractions, but not a lot, less than about 30% emptying of the bladder. But if you stimulate the bladder after the external sphincter has been relaxed, you get almost 90% efficiency in terms of bladder emptying. And you can see the difference in the amount of pressure that the bladder has to generate when it's faced a closed sphincter versus an open sphincter. And so the benefit of this is less surgery, but you're able to artificially control how the bladder and the sphincter work. So that's an example of how to try to set the depth of your talk to fit the audience. Okay. Now we're going to move on to how you design your slide. And I think the common mistake we make when we're designing our slides is we put our whole talk, we put all the words in our talk into the slide. And whether that's because you're kind of nervous and you don't want to forget something, or you haven't really thought about how to design the slide, those are common issues in terms of why the slides sometimes come out very wordy. But one of the things that I was taught early on is that the slide is a prompt to your talk. It's not the entire talk. Don't put everything on there, and definitely don't read your slide to your audience. We've all been in lectures where the professor is just droning on and just reading from the slide, and you think, I could have read this at home. I don't have to come here to hear you, read exactly what you put on the slide. However, in our efforts to make things interesting, sometimes if we put up a diagram, it actually distracts people because people are looking at the diagram instead of listening to you. And one of the issues is if you put up a lot of words or a picture, people are going to be focused on that rather than listening to what you're saying. So this is about Onuf's nucleus, which is totally irrelevant to what I'm talking about. So in terms of presentation, here's a couple of simple rules. If you can make a table, it's a lot better than putting text or making a list. If you can put up a slide that says, here's what I found, and then you put the data, that's even better. And finally, if you're working on a figure from something else, then try to crop it so that the audience can see exactly what you want them to focus on. Okay, so here again is another example of what's not so good and what's a better way to present something. Okay, same talk, and I was talking about stem cell injections for the external sphincter for incontinence. And so summarizing this from one of our textbooks in 2017, what we noticed at the initial experience back in 2013, after a few studies were done at 1 year, was that for basic stress incontinence, not somebody with combined overactivity or say post-prostatectomy incontinence, there was a fair amount of improvement. About 63% were improved, 25% were dry. For the more complicated patients, similarly, 57% were improved, but very few of them were dry. And if you injected more cells, you got a better result. Follow-up in 2016 showed that at 1 year, the number of patients who were improved stayed pretty high at 70%, but those who were dry had fallen, were still in the 37%. So even with newer technology, it was a little harder to get people dry. Now, the problem with stem cell injections is that there are 3 or 4 different types of cells you can use. There's 4 papers looking at adipose improvement with 70 and 100%, but only about 60% were dry. Muscle-derived stem cells, same range, maybe a little worse, 25 to 80% were improved. The males did much worse than the females, so only 11% were here. And umbilical stem cells, maybe a third were improved, a third were dry. And in terms of the definitions, improved just means a greater than 50% decrease in cell. When you're dosing, because nobody used the same amount of cells, the comparisons are difficult. But again, if you inject a lot of myoblasts, it seems to work, but whether they actually stay in the sphincter where you put them or where you absorb them, that's still a problem. Okay. So why do we design slides this way? And I think it's because if you're reading the paper and you're trying to summarize it and you're just typing it into the slide, this is what happens. Okay. So let me show you the data in a different way and see if this way presenting it makes a lot more Makes it a lot easier for the audience to understand what you're trying to say. Okay, so here's a table instead of a text slide. Okay, so this again, I follow up of stem cell injections for the external urethral sphincter. At 1 year follow-up in 2013, the improvement rate in both the uncomplicated and complicated patients was okay. It's about 60%. However, the patients who were dry, significant decrease from 25% to 7%. And when you follow up that data in 2016, you can see that the improvement was still durable. The dry rate was still not very good, maybe 40% here. And when you compare the different types of cells, and there's 3 of them, you can see that on the high end, you have fair improvement there. On the umbilical end, not so good. The group that seemed to do poorly were the males who got the muscle-derived stem cells versus the females, and whether that's to do with the severity of their incontinence, that might be the issue. And the definitions that were used in the study, improvement was greater than 50%. Decrease, there was no standardization of dosing of cells, and the injection, again, depended on how many cells you put in, but they didn't always stay in the same area. So again, if you can put a table in or slides which illustrate it, it's a lot easier for people to see and interpret the data rather than putting in the text where it's a little harder for them to interpret. And then finally, when you're designing your slides, here's a good example. This is talking about how MRI works. And so a lot of times we have our text over here, we have the pictures over here. And it's probably better if we just show the diagram and we speak about what we want to talk about, so that people can look at this and you're telling them what's happening over here and they can say, okay, so this is what happens with MRI. We have all these unaligned fields. When you put the magnet on, everything lines up, and that's how we then transition from the cells themselves, the atoms themselves, into the imaging that we're used to seeing. Okay, so a couple easy things to do, and this is probably specific to PowerPoint, okay, because the PowerPoint default is to have a very large header, okay, and so there's no reason you have to keep the header the same size, because in a way this is a bit of waste of space when you have so much stuff up here. You can decrease this. It's set at 44. You can drop it to 32, and you're going to have more space to put your data in here. This is a really long, hard to read header. This should be a shorter header. In terms of your list, try to keep it to 3 or 4 items on each slide so that people can understand it and not try to read 10 of them. It becomes illegible at that point. And I'm missing a picture on this slide. Okay, so this is not a great slide. So look at what happens when you drop the header to a smaller font and you keep the list of 3 items and you have a little picture here. Okay, so you see the difference. I've decreased the size of the header down to 32, which gives me more space to actually present these 3 things. And I've kept it at 1 sentence. I've got 3 lists here. Obviously, you could put 4 or 5. And here, irrelevant illustration, but this is illustration of the Weigert-Meyer rule and kidney development and where the ureter starts out, something that's familiar to us as pediatric urologists. Finally, when you're giving a talk, there is a difference here versus when you're doing a publication. This is a publication from somebody I had collaborated with at Stanford, and this was using muscle-derived stem cells for incontinence, but they had also used it for retina and cornea. This is a great illustration for a paper, but if you show this, it's not a great illustration for the talk, because what we want to talk about just here, okay, for muscular dystrophy and whether this would work for the sphincter. So it's fairly simple, now that things can be done without having to pay for specific software. You can just trim this, just crop this, okay, and then say, okay, so we're going to talk about stem cell therapy for the urethra. We're looking at muscle-derived stem cells. You can actually, the audience can see this, okay, And what we're using adenovirus injection to put these stem cells into muscle, and then we're going to see what happens as these people grow. Do they regain some sphincter function from this? Okay, so that's a nice way to make sure you're really focusing on the illustration that's important for people to see. Okay, so in summary, how do you prepare to go through your talk out loud, to yourself at least 3 times? And this is important because you want to get the timing down. You don't want to run over. And sometimes you realize what you want to say could be said a little better. Let the slide be a prompt for you to say what you're going to say just by looking at it. Again, don't read it. And then be prepared for the disaster when your slide doesn't load. This happens not infrequently when you go to a meeting. And so have your key points ready to go. But even if your slides aren't there, you can still tell the audience what you want to say. Assuming your slides work, give them an audience at the beginning. If you know the audience, go to the appropriate depth for them so that they understand it, and make your slides easy to comprehend. I think it'll just make your talk quite a bit more memorable, and it'll get the argument or the data you want to get across much more understandable. So again, thank you. If you want to get a hold of this book by Michael Alley, the illustrations are in there, and it's a very helpful textbook. Thank you very much.
Thank you very much, Xiang. So we will pass to question and answers. I will talk in Spanish. Para los colegas que nos están viendo, si tienen alguna pregunta, por favor, como somos muy pocos en la sala, son 22 personas, si alguien quiere hacer una pregunta o quiere escribirla, estamos a su disposición. I think that the presentation was so complete. And it's a difficult topic because not many people has the experience you have. So I think that it was a great presentation for me, but we will wait a little seconds if somebody has any question. But before this, I want to. Oh, okay. Alejandro is going to talk. Alejandro.
Gracias, Germán. Hello, dear Tony. It was very nice to see you again. We had a good meeting in Dallas last week. I enjoyed with the presentation. I don't have any question because it's very difficult for us to make a good papers, but the rules in your presentation, it was clear for us, and only we need to follow the guides. Thanks a lot.
Oh, thank you very much. So
I just want to say that at this meeting, Dr. Garcia and I were the only 2 that had bow ties on. Right?
Yes. Do you have the picture?
I don't have it on this computer, unfortunately. Yeah.
Yes. Send to me, please.
I do. I will.
Thank you.
So I will thank you to Anthony. He's our almost godfather in this work, because he's with us from the many years ago, and from our first talk in 5 years ago that we began our project for pediatric urology training and presentation. And thank you to Xiang. Thank you again. You are very kind to be with us, and maybe we can see each other the next time. Thank you very much for your presentation.
Thank you. Thank you for the invitation. Enjoyed being. Congratulations on your residency. I'm sure it's going very well. And anytime anyone wants to pass through Providence, Rhode Island, Young and I would be happy to host you here.
Thank you. Xiang, please.
There are a couple questions in the chat that I wanted to answer. One from Carlos.
Okay.
It says, how do you know in advance that the audience is not very interested? Okay, which is a good question. I think it depends on what it depends on the society, presentation that you're going to. I would assume if you're going to an ESPU or a AUA SPU meeting, you probably have people who have a fair amount of expertise and might be interested in it. Having been a basic scientist researcher, I face that all the time because people are like, nobody wants to go see that. So I think the issue there is trying to bring the clinical relevance of your research and putting that up front, understanding that the audience may not be super interested in all the details. They're probably more interested in what this means for them.
Tony?
Yeah, I could maybe take that question from a different angle, and that is Zoom is very difficult to give talks for me, quite honestly. I have a lot of trouble with it. But when I'm with an audience, I really take a lot of cues by looking around the room while I'm giving the talk. You're talking here, but your mind is somewhere else. You're hearing yourself talk sometimes, but you're looking at the audience to see what their reactions are. And sometimes you either have to change it up, change the pace, or throw in a joke to wake everyone up. Or if you see your audience seems to be, you're losing them, they're falling asleep, pose a question, get them to raise their hands, get them to participate in this. The most difficult time I have when I'm presenting to a large group in a large meeting is when you can't see the audience because the spotlight is on you and everything else is almost black, and you lose that interaction with the audience. And I have a lot of trouble in dealing that particular situation. I have a lot of trouble staying focused because my focus is not me giving the talk. My focus is how is my talk being received by what's going on in the audience, and changing it up a little bit, getting the audience to participate, I think is a way to keep them interested and keep them focused. So just some other cues and some other difficulties that I have to deal with.
Thank you very much. And excuse me, Carlos Alberto, I didn't see your question. I'm sorry about that. Okay, everybody's happy, and they send many thank yous for you both. And thank you again, Tony and Xiyan. Maybe the next time, as soon as possible, we will be here in Bolivia doing a mission, pediatric urology mission. Okay?
We would look forward to that.
Okay, thank you.
Thanks, everybody.
Su presencia.
Good to see you all. Bye-bye. So long.
Bye, Tony. Nice to see you again.
Alessandro, I'll send you that picture.
Okay.
Thank you very much.
Bye-bye. Have a good day,
Bye.
everyone. Thanks for allowing us to present today.
Thank you.
Gracias, Germán. Muy linda
Oh,
tu
gracias.
tu